Hi, everyone. Thanks for joining us here this evening for our latest installment of Demystifying Glaucoma. We're just going to get started here now. Mr. Thomas Gottlieb, our treasurer, will start the meeting. But before we started anything, we would like to say thank you for joining, and also to say thank you to our sponsors, Allergan and AbbVie Company. We're so happy to have their sponsorship this evening to help us bring this to you all this evening. Such an important topic. So thank you very much to Allergan and AbbVie for helping us bring this to you. And here is Thomas Gottlieb.
Thank you. Thank you, Suzanne.
You're welcome.
Are you going to put me on? Are you going to put me on spotlight?
Yes. There you go.
There I am. Okay, now you can see me bright and clear. All right. Good evening, everyone, and thank you for joining today's lecture on visual field testing and OCTs. My name is Tom Gottlieb, and I'm the treasurer of the Glaucoma Research Society of Canada. The Society is a Canadian national registered charity, which is committed to the funding of research into the causes, diagnosis, prevention, and treatment of glaucoma. We are the only Canadian charity solely dedicated to funding glaucoma research. We're made up of a volunteer board of directors, which is led by our president, Jim Parks, and our founder and chair of the Scientific Advisory Committee, Dr. Graham Trope. All of our operations are run from the CNIB building, our offices in the CNIB building on Bayview Avenue in Toronto, which is run by our administrator, Suzanne Marshall, who you just heard from. I'd like to give a special shout out and thank you to Suzanne, who organized this webinar and sent out all the timely reminders and emails. She will also be the person who will follow up with a survey and answer any additional questions that we receive by email after the lecture. So Suzanne is really the glue that holds our office together, and we couldn't do this without you, Suzanne, so thank you very much. Since 1989, we've raised over $5 million in support of over 250 research projects. Over 80% of donations that we receive go directly to the people in our hospitals and universities that are conducting important glaucoma research. Each year we receive innovative proposals from scientists and researchers across Canada to study and investigate glaucoma. These proposals are received and evaluated by our network of qualified reviewers, and the best proposals are selected and awarded grants based on the funds that we receive and that are available each year from supporters just like you. So if you have supported the Society in the past, I'd like to say thank you very much for your past support. If you would like to become a contributor tonight, please just visit our website or call the office anytime and make a contribution. So with that, I'd like to turn things back over to Suzanne, who will introduce our guest speaker and get things going. I hope you enjoy the lecture tonight. Thank you, Suzanne. Back to you.
Thank you, Tom. Thanks everyone again for joining us here this evening. My name is Suzanne Marshall, and I'm the administrator here with the Glaucoma Research Society of Canada. And it brings me great pleasure to introduce you to Dr. Catherine Birt here this evening. Dr. Birt received her medical degree from the University of Toronto in 1989 and completed her residency in ophthalmology in 1993. She went on to a fellowship at the Kresge Eye Institute at the Wayne State University at Detroit, Michigan. And currently, she is a professor in the Department of Ophthalmology and Vision Sciences at the University of Toronto and serving as a staff physician in ophthalmology at Sunnybrook Hospital. Dr. Birt is also serving as a director and vice chair of the Scientific Advisory Committee of our Glaucoma Research Society of Canada, and we are very lucky to have her. We're very happy to have her. On top of that, she is the past president of the Canadian Glaucoma Society, which is a professional organization of ophthalmologists and scientists with an interest in glaucoma in Canada. With all of that happening, she somehow found the time to put together this presentation this evening on visual field tests and OCT tests, which you're about to see. Before I hand it over to Dr. Birt, though, just a reminder that she will be answering questions live following her lecture. So you can submit a question by typing it into the Q&A field. It just says Q&A. It should be at the bottom of your screen. You can type it in there. If she doesn't get a chance to get to your questions this evening, you can send an email to me at info@glaucomaresearch.ca. Or if you think of a question following the lecture that you didn't get a chance to ask this evening, you can also send that to me and I'll forward it along to her. So that's info@glaucomaresearch.ca. And without further ado, I'll pass it along to Dr. Birt here now. Just bear with me one moment as I get the controls here. But again, thank you so much for joining us, and we hope you enjoy this evening. And Dr. Birt.
Right, well, thank you, Suzanne and Tom, for the introduction and the invitation to do this. I'm also going to see if I can get the technology. Okay, you need to allow me to share my screen, Suzanne.
So sorry about that.
Okay, not up yet. There we go. Okay, so I was asked to do a talk for the members or the supporters of the society and anyone else we could interest on the two major tests that we do in glaucoma, visual fields and OCT. What are they, why do we do them, and how do we do them? So just to start at the beginning, make sure we're all on the same page. What is glaucoma? Glaucoma is defined as an irreversible and progressive disease of the optic nerve, and it's characterized by typical changes in the optic nerve and the visual field. And what this adds up to is that glaucoma is a blinding disease. The optic nerve of the eye, the nerve that connects the eye and the brain, becomes more damaged in the glaucoma process. The more it's damaged, the less vision it can carry. Peripheral vision is damaged first, but untreated glaucoma can completely blind the eye, and in an unlucky minority of people, they can be blind in both eyes because of glaucoma. So we want to try and prevent this at all costs. The two tests that we're talking about tonight have complementary actions. The OCT allows the ophthalmologist to assess the amount of nerve tissue in the retina and at the optic nerve, looking at the physical structure of the eye where glaucoma is relevant. Visual field testing allows the ophthalmologist to assess the amount of peripheral vision that is present for the patient, which is looking at the function. When it comes right down to the bottom line, what matters is the vision the patient has. All of the tests in the world they're helpful, but what we are trying to do is to keep our patients seeing for the rest of their life. So we do these tests basically for two reasons. The first is to help us diagnose the presence of glaucoma. And the second is to monitor for progression of the disease, to make sure that our treatments are working. Generally speaking, the more abnormal the test, the higher is the probability that glaucoma is present in that eye. And one of the advantages, or one of the reasons we test, is that they can generally pick up small amounts of change before the patient, the affected person, is actually aware of any. So hopefully we can catch things before it's reached a state that is symptomatic to the patient. So these are two pictures of optic nerves at the back of someone's eye. And this is basically what the ophthalmologist will see when looking through at the back. So this is the right eye, this is the left eye. Both of these photographs could be normal. Both of these photographs could represent people with glaucoma. There's a very wide range of normal, and sometimes a single look at an eye is not enough to say whether this is an eye with glaucoma or not. Having said that, this eye on the right side, is a much healthier and more normal looking optic nerve than this on the left. what we do is we look at the nerve, which is this kind of donut in the middle, and this sort of peachy pink tissue. This is the nerve. These are composed of about 1 million nerve fibers, which are collected from all over the retina at the back of the eye and are exiting out to the brain. The central pale area is called the cup. Most people have a cup of some size between 0.1 and 0.5. The bigger the cup, the more likely it is glaucoma. So this side, you can see there's a little bit less of the nerve tissue and a little bit larger white cup in the middle. However, as I said, this could be perfectly normal, and this one could represent damage. A single snapshot doesn't always tell you enough. So we turn to some computerized tests. OCT is an acronym for Ocular Coherence Tomography. Basically, this is a technology that uses laser light that is shone into the eye, bounces off the structures at the back, it's captured by the machine and interpreted. And the machine calculates a large array of data points. And the most significant thing that it does is it compares the patient's results to normal values of people the same age. So we can get some impression right off the bat whether this is a normal test or not. Even more important, when we do multiple tests over time, the computer algorithm will compare the tests to themselves and see whether they're changing or stable. The more change we see, the more worried we are that the glaucoma is out of control. There are multiple OCT machines made and marketed. This is a photograph of the one that I have, and it's called a Cirrus. There are also machines made by Heidelberg and Stratus. It doesn't really matter which one is used to test. Repeated tests over time on the same machine is what matters. There are also some old technologies which are still valid in their way. HRT stands for Heidelberg Retinal Tomograph, which was the first computer-aided imaging system in wide use. It's not as frequently used nowadays. It's a little less flexible than the OCT, but it was a groundbreaker in its time, and it still can be a very valuable tool. And in some centers, just photography, pictures of the back of the eye can be done and compared. But most people nowadays manage their glaucoma patients with one of the OCT machines. OCT is also used in other diseases of the eye, particularly management of retinal disease and most often age-related macular degeneration. A completely different topic to tonight's discussion, but a lot of people without glaucoma get OCTs for retinal evaluation. And the user or the technician programs in the analysis program that's relevant to that patient's diagnosis. In glaucoma care, we concentrate particularly on the nerve fiber layer, which is what creates the optic nerve, and the ganglion cells, which are the layer of cells in the retina that produce the nerve fibers, which turn into the optic nerve. So when you're taking a test, there are some things to do that make it a better quality test and easier. So the first thing the technician will do is ask you to place your chin against the left side of the chin rest, keep your forehead up against the bar. Keeping the head steady allows the machine to focus. When you have your head placed on the left side of the chin rest, the machine is scanning the right eye. And when you move over and put your chin on the right side, the machine can scan the left. In the center of the view, you'll see usually a green star. And the technician should ask you to blink a couple of times before the scan starts. But once the scan is started, it's recommended that you don't blink and don't move while the scan is in progress. It takes approximately 5 seconds for most scans. And you can count it out in your head if the technician isn't doing the counting for you. So as I've said, the nerve fiber layer forms the optic nerve. So the thicker the nerve fiber layer, the less the likelihood of glaucoma. And the results of the scan are compared to normal, and a standardized color code is used to indicate whether the results are normal, borderline, or abnormal. This is a printout from the machine that I use. And the information is conveyed in different ways by different machines. So if the one you see in your ophthalmologist's office is not quite the same, don't worry about it. They're probably just using a slightly different program. This result here is printed out from a patient who was normal in both eyes. And just even without seeing the numbers, it's too small even for me to read, you can see that this is basically green. And this means that the results are within the normal range. On this side, you can see that the right eye is mostly green, but the left eye is mostly red. And this indicates that the left eye is outside the normal range and of more concern. This is just a higher magnification of that section. This yellow and red, the back of the eye is obviously not colored like this. I showed you an actual picture. These are representations. But on this scan, more red means more thickness, and therefore a thick nerve fiber layer is good. Here, there's much less red, very little, and not much yellow either. And here you can see the numbers. They don't really matter for illustration purposes. Again, you can see that this side, almost all the numbers are in green, which means they're in the normal range. And on this side, all the colored numbers are in red, which means that they're in the abnormal range. The ganglion cells are, as I said, the part of the cell body within the eye, which creates the nerve fibers that creates the optic nerve. And these are the ones that are particularly affected by glaucoma. And while they exist throughout the entire retina, they're thickest and easiest to scan in the center of the retina, the macula. Again, the thicker the layer there, the less likelihood that there is a glaucoma. And again, the scan is compared to normal and indicated with a color code. And this is what it could look like. Here again, we have a scan that is normal on both sides. There's a reasonable amount of yellow, and the color coding here for normal or abnormal is all nice and green. This is the magnification of the other side. And here you can see that this eye, lots of yellow, lots of green, normal on this side. But here, the yellow is doesn't quite fill that center ellipse quite as nicely. There's kind of some missing here. And that corresponds to this area here where the numbers are flagged in red as being significantly outside the normal range. We also have red here, which is basically showing the same thing in a slightly different way. So if you have an abnormal test and it stays exactly the same over many years, you probably don't have a problem. If you have a test that's normal, but gets a little bit worse, still normal, but getting worse, maybe you do have a problem. Stability is the key that we look for in long-term care of glaucoma. So we want multiple tests to be compared over time. And the printouts that we get will show whether there is a statistically significant amount of change between the baseline tests and the test we're looking at today. The less change showing on the test, the happier we are that the treatment is working. Now we're going to switch over and talk about the functional side of things, the visual fields. Graphically, this person is looking at a visual field. And if it's normal, the entire visual field is visible. But if you have glaucoma, then the periphery of that visual field will start to be obscured. The central part, where you recognize faces and read and watch television, is completely unaffected. And people can have 20/20 vision until very late in the course of their glaucoma. But out here, it's becoming, if not completely black, at least dimmer than it should be, and representing damage. And this will creep in until eventually the central vision is affected. And this is why we have to say that glaucoma can be a blinding disease. So your central reading vision can be maintained until very late. It's the peripheral vision that's lost earlier. So we're looking to measure the sensitivity of the eye in this peripheral zone prior to the person's conscious awareness of having a problem. By the time I see someone who is aware that they've lost visual field, sadly, it's almost always a very advanced case. Just like with OCTs, there are several machines that test the visual fields. In North America, particularly, the Humphrey visual field machine is the one that's most commonly used, but there are others, and two of the more common are called Octopus, and another technology called FDT, which stands for frequency doubling technology, which is a slightly different way of measuring visual fields. Again, it doesn't really matter which one is used as long as it's consistent so that we can look for change over time. With the visual field test, what we're trying to do is to find the dimmest light that can be seen at each of these standard test points. This means that during the test, there will always be some that are too dim to be seen. No matter how good the vision, the test will go until it gets too dim to be seen for that patient. So you're asked to push the button if you see something, no matter how dim it is, but do not push the button if you don't see anything. Remember that the machine can make a noise when it's moving from one test to the location to the next, but it may not actually project a light out for you to see. So don't push the button just because you hear the machine buzzing. Very helpful to bring your glasses, or at the very least, your best glasses prescription, because the test requires a lens for you to look through, which is not the same as your glasses, but is based on your glasses prescription. Do your best to do the test when you're alert, follow the instructions the technician gives, bring things that you need, bring in a hearing aid so that you can hear the technician telling you to start to stop, bring an interpreter if you're not working in your first language. If you're not quite sure what you're doing, and sometimes in the early days, these tests can be difficult to kind of get a hold of, ask for the instructions to be repeated, because the better test you do, the less we're going to worry about everything else in the exam. Again, sit comfortably so that your head is resting securely on the rest so that you won't move. And do the test honestly. Respond to the lights and not the sounds. Don't look around the bowl looking for the lights, because the test wants to map it to the location in your eye. It's not how many you see, but where they are seen that's important. And again, don't press the button because you think you should. Wait until you've seen a light. There may sometimes be a longer gap than others as the machine figures out where you should be. Don't click twice. If you see more than one light at the same time, just click once. If it's a split second apart, don't click the second time, because the machine's only going to give you one stimulus at a time. If something outside the room is bugging you, sit back, pause the test, and ask the technician to fix it. There's often a central spot which is intended for you to look at to keep your eye steady, but if you can't see it, do your best to keep the eye steady anyway and don't let it rove around. Unlike in the OCT, where I said you should try and hold off blinking for 5 seconds, with the visual field test, you need to blink as often as you need to, as often as you usually do. Because if you don't, your eye will actually water and blur and you'll miss more points. So a normal amount of blinking is helpful for field testing. Finally, the technician who helped me with this said, there's no winning or losing. There's no passing or failing. The test is simply collecting information to help your doctor help you. A lot of my patients come and say, I hate the field test. I feel like I'm failing every time. And that's not true. If you've done an accurate test, no matter how normal or abnormal it is, if you have been honest with your responses, then you have done a good test and you have passed. This is an example of the sort of printout we get when you've done the test. This is the actual scores that you get. I hardly ever look at that. This is a kind of an image of what you've seen. Every patient, every test should have a blind spot, which I'm showing here. Where the optic nerve is, there's no receptors. This is the blind spot. But if there are black patches here or here, those are areas where the patient who did this test was a little less sensitive than they should have been, and the test flagged it. Here's another way of showing the data. It's not quite as picturesque, but the black spots are areas that are statistically less good than they should be. So this is an approximation, we call it the grayscale, an approximation of what the patient saw out in front. But remember, these areas are not necessarily blind. You're not going to see a black hole in the middle of your vision where those areas are. The brain fills it in, even if it is completely black. But it just signals that this area was not as sensitive as it should have been. Once again, we're looking for change over time. So if you do a test, we do it again. If it's not quite the same, we'll ask you to do it again. We're looking to see whether the changes are stable, or perhaps it's just a little bit of variation back and forth, as some people have slightly good days and slightly less good days. If there's a change, then it needs to be confirmed. So that's looking for change over time. There's basically 3 ways you can make errors doing visual field tests. One we call the fixation loss. That's when the eye moves away from that central target. And so the test points are going to be shone into the back of the eye somewhere else other than where the machine thinks they are. The second is called the false negative. This is where you tell the machine, I didn't see the spot because you didn't click the button, but you saw it before. It's brighter than the ones you've been seeing. So maybe you had a brain glitch, or you're getting tired. Somehow you're not as sensitive as you were. The third one is called the false positive. And that's when you put a click in and there was no light presented at all. So the machine knows that you're a little tending to cheat. So we look at all 3 of these. The fewer mistakes in each category, the happier we are with the test results. Generally speaking, someone who is tired or sleepy will probably make more false negative errors. They'll stop catching the dim ones. Someone who is nervous or trigger happy or thinks they really have to get every single last one would click away wildly. We call them trigger happy, and you get more false positive errors. So the more errors there are, the less we can rely on the result, and you may be asked to do it again. This is a perfectly normal visual field. This is the one I showed earlier with those 2 little black spots. Black spots are getting larger and spreading. And at the end, there's only a small area where there's still some vision, and most of the rest is black. This is exactly what we're trying to avoid. Regression of the disease, loss of the function. I am going to say here that this is artificially put together. This is not a single patient being followed over time, thank heavens. This is 4 different people at different stages of the disease. This is exactly what I do not want to see happen in my patients. But rather than looking at it kind of with the naked eye, as you could in the previous slide and see the progression, we look at it a little bit more accurately with the help of statistics. This patient here has done 15 or 20 visual fields over many years. And all of the scores are up near 100%. And there's essentially no change over that time and no predicted change over the next 5 years. This person, it doesn't matter as much what the pressure is, they're doing well. This person has a visual field defect. You can see the black dots up here, but their first visual fields were much more normal. They started to get worse. The visual field went down, went down, went down. And at some point, I said, that's enough. We have to operate. And fortunately, after the surgery, they stabilized out again. So if you can't have normal all the time, if you're getting worse, stabilization after a change in treatment is the next best thing. So I'm going to wrap up with a bit of a summary now. The OCT scan looks at the structure of the optic nerve in the retina in the areas that are affected by glaucoma. The visual field looks at the function of the peripheral field, of the peripheral vision, where glaucoma problems start and before they're noticed by the patient. The aim of both of these tests is to diagnose either the presence or the progression of glaucoma to ensure that the correct treatment decisions are made. I'd like to thank you for your time and support. I'd like to thank the GRSC for putting this webinar on and for Allergan and AbbVie Company for sponsoring it. I would also like to shout out to Laurie and Kim, who are the technicians at Sunnybrook who do the tests and who helped me a great deal with putting together the test taking tips and tricks that I tried to share with you tonight. So thank you very much for that. And I've still got about a half an hour to go through some of the questions. Hopefully we can get to most of them. So the first question came from Beth, even before the webinar actually started. And the question is, difficulty seeing in low light conditions. Is there a relationship between this and the results of a visual field test? Basically, yes. There are other diseases which give difficulty seeing in low light conditions, but they will also probably have abnormal visual fields. Many diseases cause changes on these tests. Part of my job is to try and figure out what is glaucoma and what is something else. But if you have difficulty seeing in low light conditions, then the chances are that the visual field test will be abnormal. Right, I'm going to stop screen sharing, I think, because it's better for the question and answer if I keep it up this way. Okay. So the next question comes from Fania. And it says, the eye surgeon suggests immediate surgery for my glaucoma, while my ophthalmologist suggests that there's no urgency. Whom should I trust? Well, an eye surgeon is an ophthalmologist. I'm wondering if the other professional is an optometrist who is not a surgeon. I can't tell you, hopefully they both have your best interests at heart. And you'll have to sit down with the surgeon and ask them to be more clear about why they think it's urgent. But that's a question specific to you, and I can't answer more than that. Next question is from Diane, and saying, is there a correlation between OCT, visual field, and intraocular pressure changes? Good question. Lengthy answer. OCTs and visual fields are correlated. Generally speaking, and there's exceptions to every rule, we sort of feel that most people will see changes in the OCT first, while the visual field remains fairly good. And later on, the OCT may be completely uninformative, and the visual field is more what we rely on. The intraocular pressure is what we treat. It's what we look at. It's the #1 risk factor for developing glaucoma. But you can have bad visual fields and normal or even low intraocular pressures. And you can have high intraocular pressures and have absolutely normal OCTs and visual fields. So the intraocular pressure is less correlated to the test results. Having said that, if your pressure is too high for too long, you will get OCT and field changes. So it's not like the IOP, the intraocular pressure, is not important, but any particular level within the normal range or a little above can be normal or abnormal depending on the person. Next question from Vicky. You're welcome, thanking us for the webinar. The question is, can glaucoma give someone photophobia? Generally, no. Photophobia comes from a number of other things, including inflammation in the eye, cataract, something that breaks the light up. But mostly glaucoma is asymptomatic, people don't notice anything very much. Or they notice difficulties with light and dark adaptation, slow adjustment to dark conditions. But typically photophobia, meaning being dazzled by bright lights, is not a symptom. Okay, next question from Angelo. Can vascular health of the eyes for retina and optic nerve also contribute towards cause of glaucoma? If so, are there ways one can diagnose vascular health of the eye? There's been an enormous amount of research over the last 25 years or probably more, looking at the vascular health, so the flow of blood into and out of the eye. So far, there hasn't been a test which has been sufficiently sensitive and specific enough to be used for glaucoma diagnosis in the range of the blood flow at the back of the eye. There's a strong sort of belief in the glaucoma field that those with glaucoma at normal pressures may have some disturbance to the optic nerve, but it's not something we measure, not something that we at the moment give a specific treatment to. If you have a complete disturbance of the vascular flow into the eye, the central retinal vein blocks off, or you have diabetic retinopathy, that can predispose towards a specific subtype of glaucoma, but that's a little bit perhaps too nitty-gritty for a talk like this. Okay, there's another question from someone asking about their own situation, and I'm afraid I am going to skip over this. Next question from Myrna says, what is on the horizon for new tests, new equipment, and or artificial intelligence to trend more data and new predictive models? There's a research meeting called the Association for Research in Vision and Ophthalmology, which has been virtual for the last 2 years, sadly, where one goes to see what's just edging over the horizon. There's quite a lot of interest in artificial intelligence, deep learning, in eye disease in general, trying to get the visual fields and the OCTs to leverage some of that technology to get better diagnosis, especially for remote care, so that people in the far north can be diagnosed without having to trek all the way down to Toronto. All very exciting. I don't know whether I will be using that kind of technology in my practice in the next 5 to 10 years. I wouldn't be surprised if I didn't. I'd be very pleased if I could. Okay, just having to chug up and down. Another quick question about webinars on the treatment options with high pressures. We might do that. Put it in as your request when you get the survey. Okay, question from Rafe. Thank you for the webinar. On the OCT printout, the vertical cup to disc ratio is listed separately. Does the vertical cup to disc ratio matter more? Yes, it's felt that glaucoma damage to the optic nerve is a little bit more early at the top and bottom of the optic nerve, so that changes occur in the vertical direction more than the horizontal direction. So we tend to look at that with a little more attention. Okay, from Dominic, which is a better test, visual field or OCT, to indicate or predict accurately the optic nerve health? I tried to suggest that the two tests do complementary things. One is looking at the function, which is the field, one at the structure, and at different stages of the disease, one test might be a little bit more favored over the other. I would hate to have to use only one. I really want both because they're complementary. Okay. Another question about a personal point I'm going to skip. Question from George. Are there patients in which damage to the optic nerve is reversed? And there was another part to it. There we go. And what could help with that? There are occasionally reports of people where you do a very high pressure, you lower it well with surgery, and some of the damage appears to reverse, perhaps because the nerve tissue was compromised and suffering, but hadn't actually died off. Once the nerve tissue is dead, you've lost the nerves, we cannot currently make them grow back. And there's equally a lot of research looking into protecting the optic nerve against pressure and getting it to regrow, not currently possible. Okay, so question here from Shirley about, due to severe short-sightedness, the ophthalmologist said that the OCT would not be meaningful. Are there other tests besides visual fields? So yes, if your baseline tests are outside the normal range, then the test will only indicate that you're outside the normal range, and it might be from any one of a number of reasons, like being highly short-sighted or having other diseases in the eye. Sometimes you can still get information about change. So the test may not be completely worth nothing. And sometimes we have to go on to looking at other tests like the visual field. In some people, the tests aren't helpful at all. We just have to do our very best with by keeping the pressure down. Question from Anonymous about, is it safe to wear contact lenses if one has glaucoma? Generally, yes. It can make taking drops a little bit more complicated, but it's not usually a major problem. Okay, question from Marilyn saying, I can no longer do a visual field test due to hand issues. Are there other tests being researched to deal with people with hand disabilities? I'm not sure of all the variations in visual fields that are being studied. There are some that are looking at virtual reality headsets and so on. They may be measuring in ways other than requiring a clicker. But I don't have a specific answer. Okay. So another question from Anonymous asking about the GCC measurements in the OCT. What is the significance of FLV being normal and GLV being abnormal? I'd have to look at the test results, I think, to be able to give you an answer to that one. Question from Dominic saying, I rest my chin on the chin rest, but my eye is not at the same level as the center target. Does it matter? Broadly, the more centered you are, the better. The technician should be able to adjust things reasonably well to get you centered, but small deviation is probably not that much of an issue as long as you look steady and answer accurately around. Questions I fear are coming in a little faster than I can answer them. Question from Patricia, are there best types of glasses for those with glaucoma, bifocals, progressives, etc.? Short answer, whatever works for you. There's nothing specifically good or bad for the glaucoma. Okay. Question from someone anonymous, many provincial health insurance only cover eye exams once every 2 years. Yes, in Ontario, and that's the only one I can speak to, medical disease, whether it's glaucoma, diabetes, macular degeneration, are covered, and you can have as many exams as you need. Question from Ralph, after trabeculectomy, which is surgery, what can be done to bring pressure down from 13 to preferably 10 other than drops? Well, probably drops. Sometimes the surgery can be worked on, but getting from 13 to 10 is not an easy thing to do. We seem to be getting out of the visual field questions here. Okay. Anonymous question again. Does the elevation of your head while you sleep affect your glaucoma? Does it cause a headache upon waking up? No idea about the headache. Generally, it's felt that when you lie flat, your eye pressure actually goes up a little. And if you sleep with a slight elevation, you may actually be doing better for your eye pressure overnight. There's some research that's been done in Toronto by some of my colleagues, but it requires a sleep lab and is difficult work to do. Okay. Question from Peter saying, my visual field graph is decreasing over time. I now have limited vision. Will the decreasing trend ever become, I'm not sure if it's asymptotic or asymptomatic. I'm assuming from context that he's asking whether the trend will slow down so that the limited vision will remain. Hopefully, yes, not necessarily. As I said at the beginning, glaucoma is a blinding disease, and sometimes, despite our best efforts, the visual field loss just keeps going until there's nothing left. We do our very best to avoid that, and I don't know, I'm not going to say what your own personal prognosis is going to be, but sometimes we can't slow it down despite our best efforts. Anonymous again, I'm hoping this is multiple different anonymous people asking about whether there's an ongoing study looking into a reversal of blindness. Again, that would require the ability to regenerate the optic nerve, grow neurons from the eye back into the brain and have them hook up to the next step in the visual cascade in the brain. Might happen. I don't see it imminent. Question from Cindy asking, what do you tell your patients who ask about the use of marijuana to treat glaucoma? It's a good question. We don't get asked as often as we used to now that the glaucoma is, that marijuana is more available, but I don't recommend it. The Canadian Glaucoma Society doesn't recommend it. The American Ophthalmological Society doesn't recommend it. Marijuana does lower the eye pressure for 2 or 3 hours while you're stoned. But glaucoma control requires steady 24-hour pressure control as smooth as possible. You're not going to get that by smoking once a day for 3 hours. And if you're going to smoke every 3 hours to keep your pressure down and be stoned all day, that's not a good treatment for your glaucoma either. There's also the concern that it affects the blood flow to the back of the eye, to the optic nerve, and may actually be counterproductive at the same time as it's lowering the pressure. There's some interesting research looking at parts of marijuana, some of the active molecules, to lower pressure rather than without having the mental side effects, but very premature. There's also some evidence that the CBD oil, which does not make you stoned, might actually have the counterproductive effect of raising the eye pressure. So I generally tell people to stay away from stay away from marijuana, especially if the disease is bad. Okay, question from Kerry. There seems to be more people who have normal pressure glaucoma. Has the incidence increased, or is it just that screening is picking it up earlier? Good question. Either of those, I would think probably there's just more screening. 20 years ago, maybe a little more now, it was generally felt that you didn't have glaucoma unless your pressure was over 21, and then you did have glaucoma. It was just kind of a hard line. Now we know quite well that's not true. So people are more on the alert to look for other signs of glaucoma than just the pressure, so that we pick it up as early as possible. Next question from Anonymous. Does a high level of myopia predispose the patient to glaucoma? Myopia or being short-sighted is generally considered one of the risk factors for developing glaucoma. Very high short-sightedness has other issues as well, but certainly people with high myopia should be at least screened for glaucoma on a semi-regular basis. Okay, question from Debbie. Is surgery successful in stopping the progression of glaucoma? I think I just lost it. Yeah. And what are the risks? Okay, we're planning a surgical seminar later on. So I'm not gonna go through all the risks and benefits of the surgery. It can be successful in stopping the progression of the disease, but nothing is, not always, and there are risks. But if we feel that the risk of the situation untreated is greater than the risk of the surgery, then we're going to recommend surgery. Okay, Anonymous. If OCT and visual field remain stable, how would you deal with elevation of eye pressure, drops or laser? Yeah, drops or laser. If the pressure is high enough that it really requires treatment despite the field and the OCT remaining stable. If the disease is stable, probably allow the pressure to run a little higher without worrying about it. And if the disease is progressive, then the opposite is true. Okay, from Brenda, do you recommend laser iridotomy in patients with higher than normal pressure but normal visual fields? Only if they have the narrow angle configuration that reaches the criterion at which we recommend laser iridotomy. That is for acute angle closure and not the open angle glaucoma that we're really talking about long-term testing for. From Patricia, is there a standard by which you decide the loss of peripheral vision means no longer driving? Yes, the standard is set by the Ministry of Transport of Ontario, and it requires that the visual field have no defects within the central 120 degrees laterally and 15 degrees above and below, at the level that the ministry has decided to test at. So you can have an abnormal glaucoma visual field, but still have a legal driving field. However, very often, if the glaucoma field is bad enough, the driver's field will be affected, and then that mandates the ophthalmologist to let the ministry know, and the Ministry of Transport will pull the driver's license. This is always a very difficult conversation to have with the patient because their vision is usually good, and they're often very unaware of their glaucoma. It doesn't affect their day-to-day living, and yet they are going to lose their driver's license. That is because the standard for the visual field is set, as it should be, fairly tight to maximize the safety of everyone else on the roads. Question from Sharon: can eye drop medication control glaucoma indefinitely, or will surgery be needed at some point? Some people stay on medications their life and have no problems. Other people go on to surgery. So the answer to that, I'm afraid, is it depends. Question from Carrie: how often should these tests be done? Once or twice a year is pretty standard. If the situation is unstable and the tests are getting worse, then they'll be done more often. If the situation is very stable and the glaucoma is very mild or just suspect, then perhaps just once a year. So like an awful lot in this field, it depends. Question from Peter: are there some exercise-like activities like 8 hours of sleep with eyes closed, eye exercises, etc.? No, there's no exercise that's going to have any impact on your eye's ability to manage its pressure or to improve the health of the nerve at the back. So no worries about exercise. Okay, that one we did. Question from Philip: is there a connection between cataracts and glaucoma? Not really. They're both more common with increasing age. So you tend to find them coexisting in older people. Increasing cataract can lead to an angle closure situation. So the acute angle closure glaucoma that I mentioned briefly before. And there's a couple of very sort of unusual glaucomas that can be caused by a lens that's too big or getting too mature, but those are very rare. Follow-on question: would removing a cataract lower pressure? Usually a little bit, 1-2 points perhaps. It probably just taking the cataract out allows the drains to kind of open up a little bit more. It's not usually enough for a significant glaucoma treatment, but it's a nice little bonus when you do the cataract. Okay, there's a question from Dominic about double images after watching television. Probably when your eyes are closed, the muscles just drift out a little bit. When you open the eyes up again, the images snap back together. But I'm not an expert in double vision, and if it is a problem, you need to see someone who is. Question from Anonymous: are there less invasive surgeries than trabeculectomy? Yes, there's a whole series of new variations on surgery called minimally invasive or micro-incisional glaucoma surgeries. They are a little less invasive, they're a little safer, and they're also a little less effective. So they're not the best fit for everyone, but they are options. Question from Annie: how much time in average before someone will become blind? Well, it depends on how bad the glaucoma is when we start the clock. If you take it from someone who's normal and then develops the very earliest glaucoma and they're not treated, because hopefully treatment will prevent them from going blind, loss of vision to a level of legal blindness might be 15 to 20 years. But if it's a very aggressive form of glaucoma, it might be less than 5. So it's not something that you can say, oh, I've got 15 years, I don't have to treat it and leave it. I will treat someone in their 90s because I don't want them having an aggressive form of glaucoma that's going to blind them when they're 95 and they spend the last 2 years in the dark. Okay, question from Anonymous, basically about the difference between brand name and generic names. On the whole, the generics work pretty much as well as the brand names. Sometimes they're not quite as comfortable because the preservatives are different. I will generally go with the generic unless there's a specific reason for choosing a brand. Question from Brenda about, has there been any correlations between eye drops and any other negative long-term health impacts such as cancer? What a horrible thought. To the best of my knowledge, no. You can get some systemic side effects from some eye drops, but generally stopping the eye drop solves the problem. Question from Carolyn, any studies on the effect of diet on glaucoma? Lots of studies, or at least some, nothing very useful. A good healthy diet, lots of green leafy vegetables, that sort of thing. Nothing that's really going to specifically improve glaucoma control. And there's another question from Anonymous about lifestyle changes, essentially asking the same thing. And the answer is much the same. Broadly speaking, aerobic exercise, a good healthy life is good, smoking is bad. The only thing that occasionally we'll mention, if you have bad glaucoma, it's advanced, it's progressive, it's getting worse, then, okay, and this is actually the last question that I'm going to answer, just popped up. Avoid head down exercises, so downward dog in yoga, headstands, spine stretching. Avoid heavy resistance training, so massive weight training. Those have been shown to increase the eye pressure. And if your disease is getting worse, despite what looks like good control, and you're taking your drops and you've had your surgery, those might be things to think about, whether they're impacting your day-to-day activities. But in someone whose glaucoma is well controlled, stable, there's very little need to affect your lifestyle particularly. So I think that's a good point to end on. I'm impressed at the range and insight of some of the questions that we've gone through tonight. And just on 8 o'clock, thank you all very much for attending, and keep your eyes out for further invitations to more webinars and our annual supporters meeting in the fall.